So now may I call upon Dr. P. Radhakrishna. He'll be speaking on role of laparoscopy in liver disease. He is a senior consultant surgical gastroenterologist at Apollo Hospital, Chennai.
Chairpersons, senior members of faculty, dear friends. It's a privilege to be here on invitation of Dr. Mishra, and never a day goes when we don't talk about Dr. Mishra in our unit. One of the best teachers I ever seen, and not just is one of a great human being to be with. And then thank you, sir, for making a thing of this sort possible. And after a very exotic presentation of bariatrics, I shall say something very basic which we practice on a day-to-day basis, and then I'll be talking about the role of laparoscopy in liver diseases, the current status. And the screen is a little bit I shall introduce the topic, and I'll talk a few words about the role of laparoscopy in liver biopsy, the treatment of liver cysts, which we do quite often, and the role of laparoscopy in treating liver abscesses, and then what is the present status of laparoscopy in liver resection for colorectal metastasis and liver resection for hepatocellular carcinoma, and then present situation about donor hepatectomy, and then a word or two about lap liver surgery in children, and a few other lap procedures, and I shall summarize. Now, actually, what was believed earlier what is now believed is only imagined some time ago, as you see that so much technology has come in, and I think we are very lucky to be alive in a period in which so many changes are taking place in the field of surgery. Now, regarding the role of laparoscopy, diagnostic laparoscopy and liver biopsy is something which we do so very often, and there's considerable literature to suggest that laparoscopy can be performed safely and patients under local anesthetic, and then not only can diagnose the disease, and also just looking at the liver, we can come to certain conclusions what is that we are dealing with. And then these are the various pictures. You see how diagnostic laparoscopy look like, especially we do quite often for patients with ascites of unknown etiology, where other investigations do not really give us a clear picture as what you are dealing with. And then the things to remember is that we generally use under local anesthetic, or preferably a daycare anesthesia, use a 5 millimeter 30-degree telescope. We need to have an aspiration needle, punch biopsy, and bipolar diathermy forces, because when we take a punch biopsy from the liver, sometimes they may be bleeding. And then, of course, we have to make sure that the fluid is sent for cytology, bacteriology, and the liver bit also for histopathology, bacteriology, and we need to take a bit of peritoneal biopsy. There are times when all these are taken, but some specimens not been sent, and then we cut a sorry figure. But then when we are doing diagnostic laparoscopy in ascites of unknown, we should be aware of the phenomenon of carpet medicine. We had an occasion or two when we punctured the umbilical area, where punctured bunch of veins, and that will be a danger, but we should keep in mind about this condition. And there are times when we do a diagnostic laparoscopy in tuberculous abdomen. At times omentum or bowel can be stuck just under the abdominal wall, and there are very good chances that we might perforate one of them and get in trouble. And the other thing which we see often in patients where we do diagnostic laparoscopy for liver related disease, we have ascites, and there is ascitic leak if we make bigger incisions. So a 5 mm trocar incision with a very nicely tightly sutured aperture is a good thing to do. And then, of course, we always try aspirate ascites completely so that there will not be a leak there. And these are things to remove diagnostic laparoscopy. Liver cyst is something which we often encounter, and the laparoscopy is a very good procedure for this. And then there are enough literature to suggest that laparoscopy marsupialization of cysts of any size as effective and as safe as open procedures. and then of course the patient recurrence rates are less, and also they need to stay for lesser time in hospital. Now, even the long-term results of deroofing of laparoscopy deroofing of liver cysts have shown that the recurrence rate are uncommon, and then the results are good. And all that you need to do is to make sure that there are no vessel inside the wall there, because there are times when one of the big veins can be there, can get cut when you do a harmonic marsupialization. And second thing is the marsupialization should be reasonable, otherwise sometimes this can get stuck to the abdominal wall and this cyst can recur. And then laparoscopy is a very good method of treating liver cysts, and not just simple liver cysts, even polycystic liver disease, where we can go in and really aspirate or fenestrate the biggest cysts which are symptomatic, and we can do this often to make sure that patients are symptom free. Now, hydatid is one thing which we see so often in our practice in this part of the world, and hydatid laparoscopy is shown time and again to be a much more effective and much more result oriented in treating this. We have good equipment for that, and there's also literature support to suggest that there are now a lot of advantages of laparoscopy when you're treating hydatid disease. Now we have a good troca here where we can avoid spillage, and then usually with these patients we put on albendazole 2 weeks prior to the procedure, and we haven't come across situation when there is anaphylaxis or abdominal hydatidosis subsequent to the cyst aspiration and marsupialization of this hydatid cyst. Hydatid cyst, again, laparoscopy is a very good method. And then liver abscess is one area which I want to stress upon, and liver abscess is so very common here. We have occasions where radiologists can only aspirate a little bit of the pus, leaving a lot behind. There's a pus is thick, located in a very unusual area, and we also have seen that they may require repeated aspiration. Pigtail catheters there for a long time, but still they don't completely evacuate the abscess, and patient requires to come to hospital quite often. And we have found that laparoscopic aspiration liver abscess is a very good treatment. We just go in, aspirate it completely, go into the cavity, take a wall for biopsy, and then also we have a look at the liver and rest of the abdominal cavity to see where any other disease is present. And liver abscess aspiration is a very good treatment modality with doesn't require a re-intervention. And that's how the liver abscess looks like quite often, and you can completely aspirate it off and take a bit of a tissue as well. Well, then there are so many advances have taken place in laparoscopy while treating liver diseases, and there's enough literature that is accumulated about the role of liver resection laparoscopically, and this is a single center experience, and they say that laparoscopic hepatectomy for hepatocellular carcinoma is feasible and safe in select patients, but all of them once again keep saying that it should be done by surgeons who are good both at liver resections and also at laparoscopy. And this some other literature to emphasize on this point, and then here a huge experience about 177 lap liver resections, and they also feel that in experienced hands. Unfortunately, de novo liver resection is very uncommon in our part of the country. We see a lot of cirrhotics coming with HCCs, and also we hardly see solitary liver metastasis in carcinoma, colon and rectum. We always see multiple metastases for some reason, and generally our national experience in liver resection is very, very little as compared to the West. So these things, when done, should be done in centers where they have a lot of liver resection going on, as well as laparoscopy. Now, this is a world review of about 2,804 patients' liver resections. They all felt that in experienced hands, lap liver resection is safe and with acceptable morbidity and mortality, and even oncological results at 3 and 5 years survival as compared to open surgeries, with very little pain and very early recovery for these patients. And there's an international conference where a lot of liver surgeons from all over the world met in 2008, and they come with statement that laparoscopic liver surgery is safe and effective, and the management of surgical disease in the liver, and it should be done by trained surgeons with experience in both hepatobiliary and laparoscopic surgery. And then, of course, there are so many experimental methods have been adopted where the people tried ligating the portal vein laparoscopically and subsequently went laparosection, and then earlier, right hepatectomy seems to be a very major procedure laparoscopically, but now a huge accumulation of literature is there on safe performance of right hepatectomy by laparoscopy. Now, there are two-stage procedures as suggested earlier, ligation of portal vein and subsequently going for surgery. And of course, also the role of laparoscopy in treating inoperable liver lesions in cirrhotics by using lab-guided radiofrequency ablation. And then there is reasonable literature to support that as well. And then in pediatrics, laparoscopy has been used reasonably to remove huge tumors of this size with very small incisions. And then, of course, left lobectomy for transplantation has been done in even our own country in Medanta, where they have done removed left lobe initially by laparoscopy and now by robotic surgery. And this is an advancement in laparoscopy and liver disease. And then and there is gathering experience worldwide as well in laparoscopic left lateral sectionectomy as well as left lobectomy for liver transplantation. Now, that's how the scars look at end of the procedure. And then my purview doesn't come under the role of robotics in treating liver disorder. Robotics has come in a big way, and what all have been mentioned till now, all have been done robotically, and we are getting more and more literature in this regard. So, in summary, ladies and gentlemen, as far as the role of laparoscopy in liver disease is concerned, liver biopsy, it's ideal. It can be done as an outpatient procedure or as a daycare procedure. Liver cysts, once again, laparoscopy is very ideal, where we can deroof the cysts and give a complete clearance. And lap hydrated, and this is another area where laparoscopy is very useful, where we can completely suck out and do a complete marsupialization, preventing it from recurring. Liver abscess, I get your attention. The liver abscesses which can't be treated well by percutaneous methods, one should consider laparoscopy, once again as a daycare procedure. Of course, lap liver resections, donor hepatectomy, and many more are happening, and laparoscopy has come to stay in treating liver disease. Thank you so much for your patient listening.
Thank you very much, sir, for that crisp presentation. For your information, Dr. Radhakrishna is a senior gastroenterologist in Apollo, Chennai. He's very interested in teaching, and he always, he spellbinds the audience, and he's a big, star with all the students there. And he's also got a special interest in portal hypertension surgery. So he'll take any questions from the floor now. Please.
Thanks for your presentation. In these cases with advanced liver cirrhosis, with ascites, patient can go to horrible bleeding, and it could be life-threatening, and the surgeon should be ready for shunting the patient to save his life. What is the percentage of these cases you came across?
Now, generally we've been referred patients by gastroenterologists after they have exhausted their diagnostic armamentarium to see whether it is cirrhosis or tuberculosis, or they are not sure what is the cause of ascites. Patient with obvious cirrhosis, there's no need to do a laparoscopy. We know we have by indirect methods, by imaging, by liver functions and endoscopy, the patient is cirrhosis. So we don't do in those patients. We do only in patients where there is a doubt whether it is cirrhosis. Where we have come across, well, all of the investigation negative, laparoscopy shows a nice cirrhotic liver. So we don't get that sort of patients with coagulopathy and shrunken liver to go in for laparoscopy.
Usually as a general surgeons, what we used to do previously was, ultrasound guided aspiration of the liver abscess. So has the protocol changed now that, as you say that the laparoscopically we can aspirate out almost the cavity. So, so what is the timing of your aspiration?
See, we have seen actually when I was under training on GI surgery at Dr. Rangabhashyam and subsequently Dr. Samran Nandi, what we have seen is these patients get aspirated again and again and again, and we don't know whether it is complete. And these patients keep coming to the hospital quite often. And some of them we have seen when we send to the imagologist, they put a pigtail catheter and we don't know when to remove it, and it's never complete. We see some it remains all the while. And we have, in our personal experience, noticed that put a laparoscope, suck it out completely, including that necrotic debris on the floor of the abscess, and they do very well, and they don't come back again. So we feel, instead of putting the patient to so much expenditure and coming to hospital so many times, a laparoscopy through a 5 millimeter pore, we can simply suck it out completely and cure it.
I think that is the message, because
We do, yes, we do, and we just remove it after a day or two. After, when you see bile staining, which is very unusual in liver abscesses, we are a little more worried. Of course, we have good gastroenterology backup for ERCP, etc., if necessary.
thank you very much, Dr.
Thank you,
Rajkumar.
sir.
Thank you so much.